the principles, tips and tricks or guidelines. My name is Dr. Yamal Patel, Third Park Hospital, Nairobi. What are we going to be discussing today in reproductive surgery? Number one, definition, evolution maybe briefly, classifications of surgeries, some controversies around it, the principles, and maybe the guidelines or the tips. The intent of reproductive surgery is to maintain fertility or treat conditions that impair fertility. Okay? And the goal is a healthy baby. It doesn't end with a positive beta HCG. It's a healthy baby, a live birth rate. Okay? That's our goal in reproductive surgery. It's classified into two. We have fertility sparing surgery and we have fertility enhancing surgery. Okay? So, fertility sparing surgery is fertility preservation in the face of disease. Fertility enhancing surgery is fecundity enhancement in the setting of spontaneous or assisted reproduction. So we have to understand these two concepts differently. What is sparing? What is enhancing? And then there is also male reproductive surgery, which includes the varicocele, obstructive disorder surgery, and non-obstructive disorder surgery. So we're not going to covering that, but because that is not falling in our domain as gynecologists, but it is part of reproductive surgery. How? Well, we have to understand how reproductive surgery is done. It is done personalized in timing, in the indications, following certain principles, if possible, minimally invasive wherever it's possible. And it is therefore difficult to have all these in one person. Who does reproductive surgery? Ideally, it will be gynecologists with reproductive endocrinology and infertility knowledge, and with the skill set for reproductive surgery, especially or ideally minimally invasive. So having this combination is not that easy, meaning they cannot be only reproductive endocrinologists and infertility specialists, but they have not excellent reproductive MIS skills. So you may be an IVF specialist, that doesn't make you a reproductive surgeon. Are we getting it? Because you may not have the full skill to do reproductive MIS surgery. And you may be a very good MIS surgeon, but with poor reproductive endocrinology and infertility knowledge, which means you're too aggressive and you're not respecting the tissue in a bid to improve fertility. That also doesn't work. So someone who is going to be having a mix of these two is very important. This is evolution of reproductive surgery. Previously, everything was done by laparotomy. Then came in open reconstructive tubal surgery, where it was done by the microsurgical principles. And Victor Gomel, Kurt Sem, and many of these people are known names in reproductive surgery, microsurgery technique. Then we have diagnostic laparoscopy was added to it, where you could try and quickly go and see what is happening and then proceed with, if you need to open, to do more surgery by open. Then came in the operative diagnostic and operative hysteroscopy, which started. And then now you get operative laparoscopy, which is now finally coming to operative reproductive hysteroscopy and laparoscopy, which means the person's intention are to improve, enhance, or spare the fertility. And that is different from just doing laparoscopic or hysteroscopic work. Your goal is very different every time, keeping fertility in mind. What are the various reproductive surgeries available? There are so many, you'll see. We have fertility enhancing surgeries like Tubal surgery involving the hydrosalpinx, rhianastomosis, tubal cannulation, proximal block, salpingo-ovariolisis, adhesions where they are the tubes due to chlamydia adhesions, fimbrioplasty because the fimbria is blocked and covered up, you open it up and do fimbrioplasty. Uterine surgery could be myomectomy, especially if it is submucous, adenomyosis, especially if it's focal, Mullerian anomalies, metroplasties, and septum resections. Fertility enhancing goes on with ovarian surgery for laparoscopic ovarian drilling for PCOS and maybe cystectomy sometimes. Pelvic surgery could be adhesiolysis or abscesses and PID that is collected and you have to clear that area. And then comes the endometriosis surgery, infertility for DIE surgery, keeping fertility in mind, cystectomy, sclerotherapy, drainage and ablation of the endometriomas if needed. Posterior peritonectomy has been found to enhance fertility. We go to hysteroscopic fertility enhancing procedures, submucous myomectomy, Asherman's, polypectomies, septum resections, metroplasties, endometrial scratch, endometrial rejuvenation by instillation of maybe stem cell or the PRP, tubal cannulations, adeno resection of the lesions that are subendometrial. They really change the outcome of these patients. And pre-IVF diagnostic hysteroscopies has been also there. So these are so many procedures that are fertility enhancing. What is fertility sparing? Ovarian wedge has been taken for tissue cryopreservation. Ovarian transposition before radiation is given for malignancy in the pelvis. So you put them away so that you don't expose this to radiation. Ovarian activation and autologous transplantation after IVF and ovum freezing. Tubal sparing ectopic surgery. So you get an ectopic. I was asking you yesterday, if you remember, have we tried a tubal sparing ectopic surgery? Have you done salpingostomy? I do quite a number of times salpingostomies to save that tube if it is not already damaged. If it's damaged, it's different. But that's tubal sparing, because if you remove one, you're left with one. You get an ectopic the other side, you remove the other one, and we have a problem. You see what I'm saying? So is it possible to save? Think about it. Cervix, fertility sparing radical trachelectomies have been done. So imagine how many surgeries fall under reproductive surgery, okay? What are the controversies? These are the controversies. We know surgery has been said to increase risk of post-op adhesions by direct trauma, by ischemic and thermal injury, by damage due to drying and trauma with gauze and sponge, the lint, by bleeding and blood left in the cavity, by introduction of foreign bodies like talc in your gloves, by use of reactive sutures which cause inflammation, and by post-op infections. So all these things worsen adhesions. So that's why you will get some of these IVF specialists repeatedly say, no to everything, no to surgery. And they may not be right. I mean, they may not be wrong, but they're not absolutely right either. They are not wrong because if surgery is done without the right principles of reproductive surgery, you're going to do more harm than good to that pelvis. You understand what I'm saying? So if they don't know that this guy is a reproductive surgery with the right skills to do it, then they're better off saying, don't do it, I'll try IVF. And surgery, therefore, can worsen outcomes due to these factors. So, does ART render reproductive surgery obsolete? Is IVF the answer to every infertility issue? I beg to differ. And I beg to differ because I happen to fall into the group that I can call myself a reproductive surgeon. And the reason is I do follow the principles that I'll be talking to you about. Okay? What are the controversial surgeries according to the reproductive endocrinologists and infertility specialists, IVF specialists? They don't like surgery. These are the controversial ones. They don't like adenodebulking. They are not sure myomectomy improves the outcomes, the ovarian drilling, endometriosis surgery before an IVF, endometrioma surgery where for cystectomy, whatever, and whether they need medical or surgical treatment for endo. These are all controversies. But there are some surgeries that have no contention. Ectopic surgery has no contention. Okay? Hysteroscopic surgery for polyp, myoma, septum, Asherman has no contention. These are known even by them to improve outcomes, okay? So what is fertility hysteroscopy now? So we are going now into the individual ones, and I'm going to give you now tips and tricks. Septum resection will improve the outcomes of that patient, both for fertility and for reducing the loss risk. Because fertility, pregnancy in patients with septum have a high risk of pregnancy loss. Okay, so you correct this, you improve their outcome to a live birth rate. Okay, then myoma, submucous type 0, 1, and 2. Lateral metroplasty for a T-shaped uterus. You saw ours was not exactly T-shaped, but increasing that slightly improves the chance of that pregnancy carrying a pregnancy through without miscarriage risk. Polypectomy for endometrial and cervical polyps. Synecholysis for Asherman's to create an adequate cavity and regenerate the endometrium using hormones later. Adenomyosis, if it is subendometrial lesions and collections and you clear them and you drain and excise that small cavity out from the adeno. I have a few videos I could see if I'll get them. But if you do that, it changes the outcome for that patient subsequently with fertility, okay? And you will start getting better IVF implantations, better pregnancy rates, lower miscarriage rates, lower preterm labor rates, and a higher live birth rate. So I told you, my final goal is this last bit. Am I giving this patient a baby in the hand, not a positive beta HCG is the goal, okay? Getting a positive beta HCG is just a percentage of the goal achieved. And that has to be very clear. What are the principles? Now we're going to the nitty-gritties of what should be done as a reproductive surgeon, okay? There were some microsurgical principles that were established in 1960s and early 70s, but mainly for open surgeries and usually for tubal reconstructive surgeries. Now, it was erroneously described earlier as surgery under magnification. But this was only one aspect of the microsurgical principles. Only one, that it's under magnification, because they used to use microscopes and do these, okay? But it's only 1%, one part of it. And until it was the only option for fertility until IVF came in. And therefore, after IVF came in, the tubal surgery is reduced, okay? So, according to me, what are the principles? Following these microsurgical principles, which I'll be elaborating on, having the correct indication, the correct timing in the reproductive age. Don't try and approach this goal of theirs by trying too many things for 10 years. The patient reaches 42, 43, and then you say, you know what, now, let's try surgery and sort these out. It's too late. The ovarian reserve has dropped. You've not benefited that patient in any way to take a decision at that point. Do it when they still have time, guys. You see, people try fertility treatment for too long. You understanding what I'm saying? Before they feel something may be necessary. And I have numerous examples like this. Numerous. Some of them I've just been seeing even in this workshop. Like this last one. Like the one I told you, the one I did the end of 4 failed IVFs. What were they trying to do their 4 failed IVFs for? Are you getting my point? Until the AMH now is 0.2 or 0.05. What are you going to do? Nothing, guys. So please, the right time. Preferably minimally invasive. Don't go open all the time. So that's why you need to learn this skill, guys. You cannot give them equal results. You can't compare the results between open and MIS in reproductive surgery. Are we clear? Because you will save lots of issues by MIS. Be radical to the disease, but conservative to function. Always try to retain function in your mind, that I don't want to damage the functionality of this tube, of this uterus, of this endometrium. So you don't go and try and remove a submucous fibroid when it is 3 centimeters. I don't do it. I would rather go laparoscopy and remove it and then repair the uterus. Not hysteroscopically. I don't want to be a hero. Number one, you have a high risk of fluid overload. Number 2, you have a high risk of incomplete surgery in a second sitting. Number 3, you're going to have to cut off all that endometrium all round to remove the fibroid, which means you have gone through the basal layer, through the functional layer, then into the myoma and remove the myoma. If we are lucky that you did not go into the myometrium. Are you now understanding? Now, if this uterus heals and develops an Asherman's, what have you achieved? What have you achieved? Doing a surgery for 3 hours, what have you achieved? Nothing. So this is what I meant. If I'm thinking fertility, then I would rather approach it from outside. It is big, it's pushing in. It might be a grade 1 or even a grade 2, but I'll open the uterus, get the fibroid out, leave the endometrial lining because it's beyond it as much as I can, and close this uterus. Did you see the difference in the two now? So why? Why not? And finally, follow anatomical surgical planes. Do plane surgeries, meaning you have to ensure you're in the right planes when doing surgery for reproduction. And that's why the knowledge of anatomy, the knowledge of planes, the dissection principles are very, very important here. The principles: you have to take care of tissue, not to injure tissue. Precise surgery, prevention of post-op adhesions, and improving fertility outcome is your goal. Principles number 1, handle tissues delicately, judiciously, and precisely use electrical or laser energy, which means you're using very precise bursts of energy, not burning too big and destroying tissue. Are we getting it? So you've heard me talk about energy, you heard Raj, you heard Charles. It's my passion topic, and I have learnt it in and out, okay? But I know that here my use of energy will be very different than when I'm just doing a surgery, okay? If fertility is the goal, my treatment, my approach of energy will be different. Identify and correctly use the planes. Excision and remove a broad adhesion. Sometimes you see those broad adhesions and like films that are hanging over the uterus and all. You have to, if they are broad, you have to cut and remove these, because you leave them, they'll stick again. They will stick again. You get my point? So the ones that are fine and simple adhesions, you can cut and leave. But when there is a filmy, you know, you have seen those filmy ones. You have to actually cut and remove all those for fertility. Are we getting it? Completely excise the abnormal tissue. Don't leave half in. Principles 2. Precise alignment and approximation of tissue planes. So when you've made a cut and you have to try and align it nicely so that they're in the same plane, not up and down, not this way, not just closing it up. Closing it up correctly is important, okay? The planes. Open surgery, you avoid drying of peritoneum by frequent irrigation using ringers with heparin and hydrocortisone. Ringers, not saline. Ringers, not saline. Saline will not help. And you irrigate at room temperature. It doesn't have to be warm. It doesn't have to be warm, okay? Lap surgery is a closed system. So in lap surgery or MIS, drying issue is less. So you don't need to frequently, I don't need to frequently irrigate in lap surgery. I did the whole endosurgery the other day without once irrigating, but I sucked many times the blood that was collecting. Why was I not irrigating? Anybody? Why was I not irrigating in that endosurgery? I was in the retroperitoneum, remember? I was in the retroperitoneum and in the planes. In the retroperitoneum, when I was dissecting, I was following planes to tell me where I have the right planes that are avascular. I will be seeing those what we call champagne effect, or those adipose like, not adipose, the areola like tissue. You saw that? I'm using that. If I pour saline there, or irrigate there with ringers, it's going to make all this wet. I'll not have the plane again. I'll not have the plane again. So not once will I irrigate while operating, if fertility is my concern. Are we getting it? I will irrigate at the end and wash the whole abdomen, but I will not irrigate during surgery. That's the reason, okay? And I don't need to, because I don't need to wet the tissue. It is a closed system. It doesn't dry that much, okay? The next thing, principle 3, prevention of foreign body contamination. Try using powder-free gloves and wet, lint-free surgical pads or gauzes. So don't use the gauzes that have lint, okay? Which means when you're open surgery, there are some that are called lint-free. They don't have those pieces. They're just pads. Use those. And use them wet. Don't put dry ones in. Don't put dry ones in. Use them wet. Wet with? Ringers, not saline. So you see now what I'm trying to change some principles, guys. All right? Please understand, it has a better outcome for fertility than saline. Don't wet it with saline, wet it with ringers. Okay? Meticulous pinpoint hemostasis with minimal lateral thermal spread. So fine bites and meticulous burns. Wherever you see a small oozer, buzz it. Don't let it ooze so much, but don't take big chunks of burning. Okay? When you leave burning, you leave ischemic tissue. Ischemic tissue will inflame the surrounding healing, and inflammation will cause adhesions. So fine point, okay? And fine instruments. For MIS, reproductive surgery, sometimes we use 3 mm instruments. I have a 3 mm set here. 3 millimeter instruments of laparoscopy. So I'm not operating with even 5 millimeter instruments. I'm using 3 millimeter instruments for, let's say, fine tubal surgery, for example, okay? Then principles 4. Thorough lavage at the end of the procedure with heparinized ringers, okay, to remove blood, clots, foreign body, and debris. So at the end, you irrigate. You've understood? But not before. Good and meticulous hemostasis would help. If you don't have, you can put something to cause hemostasis. It's not an adhesion barrier. It's for hemostasis, Surgicel, okay? And at the end, leaving around 300 to 500 ml of that ringer solution in the abdomen, maybe with some hydrocortisone succinate, if possible, 100 milligrams, would be a good idea to reduce the inflammatory response after. Okay? Principles number 5, use of magnification. So you see, magnification was only one part of the principles. And how do you magnify? You either use the loops in open surgery, or you use laparoscopy, because laparoscopy is magnified. You've understood? Laparoscopy is magnified. You don't need to magnify a magnified view. And if you have to, you can zoom in and go closer. It will zoom bigger if you have to, but you don't need to. You've understood? And if you have the advantage of 3D, even better. What you get with the depth and 3D with very fine dissection is even better. Then use fine and less reactive sutures wherever possible. Okay? So sutures like catgut and all were very inflammatory. I don't think we use them anymore. Okay? Vicryl is more reactive than PDS or more reactive than monocryl. Okay? So know when to use which one. Silk is very reactive, but silk is permanent as well. You get it? If you have to use something permanent, Ethibond is better than silk. So this is what I meant. Use less reactive sutures. For skin out there, don't use Vicryl. Never use Vicryl to close your skin. It can't. You'll get inflammation all around. So you have to use monocryl. You can use nylon, proline so that they are less reactive, and then you remove them, isn't it? But that's skin. So what makes you think the same reaction cannot happen inside? Vicryl is reactive. So you may use sutures that are less reactive. Mobilize early. Use the ERAS protocol, early feeding, because when you get early bowel movement, when the bowel is moving, they don't stick to each other. Adhesions will be less. So don't wait 2 days to feed this patient. Okay? Follow ERAS protocol. Good post-op pain control. If you want to follow ERAS protocol and mobilize early, then give good pain control. Give blocks. Why do you think we were giving blocks? This patient in 6 hours is walking on the corridor. Even after an advanced endohysterectomy or myomectomy procedure. In less than 6 hours, they are walking on the corridor. And we force them to walk. But that changes the outcome dramatically. Are we understanding? So to make them walk, they have to not be feeling pain. And if they don't have to feel pain, they don't have to feel pain because of morphine and pethidine and fentanyl. They'll be drowsy like this. They're not going to walk. So to make them not walk, you don't load them with opioids. That's not the pain control I'm talking about. It's multimodal approach. Blocks, local anesthesia, injections, mixture of NSAIDs with opioids. You get my point. This is how you do it, okay? So multimodal approach. Principle 6, prevent infection, give good antibiotic cover, post-op, starting from just before incision, so that you don't get infection, you don't have too many adhesions and a mess up of that abdomen. And keep the denuded surface sometimes separated by temporary adnexal or ovarian suspension. So sometimes when we do very difficult cases of endo, we will leave the ovaries suspended with sutures here on the skin. So the ovaries are up like that. They don't go down and get stuck in that pelvis. Then after 48 hours, we'll just pull this suture out and the ovaries fall back. You get it? So sometimes you may need to do that to make sure these ovaries don't go and stick there. Principles number 7, anti-inflammatory medicines. NSAIDs, not just opioids. Because pain control is not the only goal. Fentanyl will give better pain control, agreed. But is it having an anti-inflammatory response? No. No. That patient will cause lots of inflammation inside, but you'll knock off the pain. So anti-inflammatory has only not a role in pain control, but in reduction of the inflammatory response of the body. And maybe you may also want to consider dexamethasone post-op, some cases. Anti-adhesion barrier is just one of my last points. I don't use this. So when people tell me, Dr. Yamal, which anti-adhesion method would you use? I hardly use this. The reason is I work on all the rest of the things. These things are not known to be magic pills to prevent adhesions. If you follow the right principles, it works. If you don't, you could do the worst case and put an interseed there. It will still not work. It will not heal. You get my point? There'll still be adhesions. This is not a solution to everything, but it can be used, okay? So, how I do it. How I do it. In endo, this is how I would do. Surgery is not my first line of treatment for suspected early endo. Please don't think because I'm an endosurgeon, I always take every patient of endo into theater. No. Second, surgery, I will do it for pain and DIE. Yes. Surgery if there is failed IVF. Yes. Surgery if there is extreme distortion of anatomy. Yes. Surgery if there is hydrosalpinx. Yes. Surgery if there is additional myomas and adeno in there as well. Yes. Surgery if there is difficult access to the ovaries by IVF. In the last 6 months, I've done 4 DIE, frozen pelvis with pelvic abscess. And I have one that I'm coming back to do here on Sunday, this Sunday, after coming back from Kerugoya. Pelvic abscess with 2 big abscesses in the tubes and ovaries, and the whole pelvis is frozen following IVF. So if you have a bad, crazy pelvis, what are you trying to do going through bowel to reach this ovary to remove an egg? Coming back and leaving bowel leaking in the abdomen. What have you gained? So, is it fair that I'm doing 4, 5th one now, coming back? Her CRP is 298. Is it fair that I'm doing the 5th one in 6 months? It's not. And trust me, endo is a mess as it is. Doing endo with an added pelvic abscess is a nightmare. You get what I'm saying? So, that should not allow, if it is difficult access to the ovary, correct that first. Why are you going with IVF? This is where I fight with IVF specialists. Please, what are you trying to do here? There are certain things that are clear. Don't. I am not pro the knife, but that doesn't mean you should also not be allowing the knife when it's necessary. You understand what I'm saying? It's not the solution for everything. Surgery if endo is there and she wants to try natural pregnancy, yes, surgery, I would do it because it improves. It's known to improve the outcomes for natural pregnancies. Okay? Endometrioma more than 4 centimeters, yes. There's no point with a 7 centimeters endometrioma trying to do IVF. There's nothing you're going to gain there. So if I do it, I would do it laparoscopic, excision, conservative, yet radical. These are my principles. So I have just said, this is my way of doing it. Are we clear? I am not someone who is an authority in the world. So I'm not saying this is how it should be done worldwide. But yes, I'm an authority in my own practice. And I think I have reasons to believe these things help. Okay? Endometrioma cyst, if very adherent, I will drain and do minimal ablation. If the wall is very adherent, because when you try and pull that off forcefully, it damages the ovarian tissue. Got it? Sclerotherapy for very large ovarian cysts, I would do sclerotherapy with alcohol. Caution in bilateral endometriomas, you have to be careful if they're both this big and I remove both equally aggressively, I'm condemning her from getting pregnant with her own eggs. Okay? I have to be careful. IVF and cryopreservation of ova and embryos before extensive DIE surgery. I have at least more than 20 that I've done this way. I see that the access to the ovary is not bad. I will tell her, listen, I'm going to do your endosurgery. You are in pain. I understand. You want fertility. I understand. Can we try and send you to that IVF center? Pick your eggs up, fertilize them, freeze the embryos. Come back to me. Don't put the embryos in. I tell them very categorically, don't put the embryos in. It will fail, most likely. Come back. I'll operate on you. 3-4 months later, after medical suppression for a few months, I'll send you back to the IVF center for a frozen embryo transfer. Are we understanding? So this is how I would do in very many patients. Because I know I go in to operate on this endo, I will drop her ovarian reserve. And she may not get eggs properly after that. So why not collect them first when we can, then do the surgery, improve the environment, go and put the eggs in. Are we understanding? So this is a very important way of approaching it. In summary, for unexplained and unsuccessful fertility treatment, I would consider hysteroscopy, laparoscopy, diagnostic. But as I've said, especially after failed IVF, these have really reduced now because invariably there is a reason, there is a problem that is there. And if you can find it before going in, it doesn't become a diagnostic laparoscopy anymore. It's now an operative laparoscopy. Okay? So I rarely do diagnostics only. Fibroids, this is my way of doing it. If it is anatomically disrupting the uterine architecture and it's especially submucosal, I will tell the patient, don't try fertility with this way. Let me correct it first. You will have a better chance. If they have issues in maintaining the pregnancy repeatedly, they are losing miscarriage, preterm labor, I'll correct it because she has fibroids. If there is myomectomy and spontaneous pregnancy rates have been found to be high. If there is heavy menstrual bleeding or pressure symptoms, there is no issue. Okay? For infertility or recurrent pregnancy, it's unclear. So we don't have guidelines telling us that you have fibroids here, you have to remove them. But there are many changes that happen once you have removed those multiple big fibroids that are near or pushing the cavity. And does it affect the ART outcomes? To me, no. It will improve. Okay? These are concerns. These are all queries, questions to be answered. What is the root of myomectomy and outcomes? I prefer laparoscopic whenever possible. I do more than 80% of my myomectomies laparoscopically. Only the very big ones or very many multiple ones I would go in open. But more than 80% of my lap I would do laparoscopically. And the guidelines of reproductive surgery say laparoscopy is better, if feasible, if the required expertise is there. You get my point? So it's a prep. Then myomectomy and rupture in labor. In my 25 years of practice plus, I've not had a single rupture due to myomectomy. I mean a post-myomectomy patient. But I am very particular in what I write down in my notes after. So in all my notes, I will write down, could be allowed vaginal labor when pregnant, not for vaginal delivery once pregnant. I write it in my notes, in my theater notes and my discharge. And I tell the patient. So there are some people I will not allow them to try. If I've gone too deep, I've done too many cuts on that uterus, I don't want to try labor. Her goal is getting pregnancy and a baby. Her goal is not, I did it vaginally. No. What if you did it vaginally and lost the baby in the process because of a rupture? So you don't do that. So I am particular in writing that, and I tell them, you go for labor. You don't go for labor. You get my point. And that's important depending, it's a personal decision, but I think it has so far helped me not have a single rupture so far. Okay? Myomectomy for submucous, there's no issue. And how to assess this degree of cavity distortion by the fibroids? Is it TVS, MRI, SIS, hysteroscopy? I don't know. But yeah, I mean, these things are pretty accurate. With TVS and SIS, I have enough armamentarium to tell you where this fibroid is and how deep it is into the cavity. Fibroids and fertility, this is how I decide. Is it symptomatic and distorting the cavity? Is it symptomatic but not distorting the cavity? Is it asymptomatic and distorting the cavity? Is it asymptomatic and not distorting the cavity? And is there enough distortion to affect access due to ART? And that's when I decide, does she need surgery or does she not need surgery? It's not, go get pregnant. People get pregnant with fibroids all the time. I also have more than 15, 20 patients pregnant at the moment with fibroids. But I'm very particular about which ones I would say try pregnancy with them the way they are, and which ones I will say no. You've understood? It's not a blanket decision that your fibroids, don't worry, they are not causes of infertility. Yes, they are not, but they are causes of pregnancy issues. Preterm miscarriages, preterm labor, blah, blah, blah. There are so many issues. So correct it if possible, if it is going to have issues. So for myoma, this is my plan, my way. For submucous, these I would remove. For these ones that are large but they're pushing the cavity, I would remove. If I have very large ones that are distorting anatomy access, I will remove. And if possible, wherever possible, I'll do laparoscopic. Tubal blockage, I would do salpingo-ovariolisis for PID-related blocks. I would do fimbrioplasty if there's a fimbrial block. I would do salpingectomy if there's a hydrosalpinx. I don't save a hydrosalpinx tube, by the way. I would do cannulation if there's a proximal block, and I do not do tubal recanalization anymore. Someone has done a BTL and comes and tells me, Doc, I want to reconnect it. I said, listen, the success rates might still not be as good, and the cost is equal to IVF. Just go do IVF. Why are you bothered about doing a recanalization today? In today's world, I don't do it. There might be people doing it, that's fine. Adeno and infertility, how does it affect adeno? It causes all this. I think I have only 5 minutes. These are the controversies. Type of adeno and its impact on fertility. Does focal impact? Does diffuse impact? What is the treatment of adeno going to impact the natural versus ART attempt? In summary, yes, this is something I do. That if I use GnRH analogs in adenomyosis before IVF or before natural attempt, it increases the implantation wherever possible for 2 to 4 months before. And hysteroscopy for IVF, before IVF for adeno, I would do because I'm trying to remove those subendometrial collections, okay? The chocolate collections under the subendometrial area. For surgery, adenomyomectomy, I would prefer in focal ones because it does have a positive impact more in focal than in diffuse. It's difficult to do surgery in diffuse. There is debulking option, but the concern of the uterine wall integrity is there. So these diffuse ones, I would prefer the medical suppression with GnRH before the fertility. There is HIFU that has been used, and electrocoagulation of the adenomyosis focus also has been found to have positive impact on reproductive outcomes. But these are the concerns. How much do I excise? Is it total or partial? What is a reconstructive technique? There is U-shape, H-shape, triple flap, overlapping. What technique that will give me a stronger uterine wall? What about the scarring that will result from it? What about the adhesions? What are the risk of rupture? What about risk of accreta? So these are concerns that we should have in adeno surgeries. Definite. So the current issues would remain the diagnostic issues. It would remain that they are many times associated with concurrent, it's never alone. Many times it's with endo, it's with the fibroids, you get them there together. Would I consider IVF or surgery as an option? And if I do surgery, which route would I use? Would I do open? Would I do laparoscopic? If it's because open has an Osada technique, and it's a pretty good. It has been found to have pretty good results as well. But you have to be knowing how to do the proper Osada technique. If I do surgery, which type and the details? What is the extent of surgery? What is the technique? What is the role of these? HIFU, embolization, and medication. And we have to understand another thing. Adeno and high-risk pregnancy. Adenomyosis is a known cause for high-risk pregnancy. It has high risk of lots of complications during pregnancy. It doesn't fall under routine pregnancy. So when you get an adeno patient pregnant, please take care of this patient more regularly than a normal patient. If you can't, send them over to a high-risk pregnancy specialist, okay, HRP specialist, because these are high-risk pregnancies with a poor outcomes. In summary, for PCOS, I've not done an LOD, laparoscopic ovarian drilling, in a very, very, very long time. All right, if PCOS patients are not getting pregnant, I'm not saying I've never done it, but it's been a long time now. For fertility, I would refer them to IVF team to handle it. It has good results with that. For other things, maybe I may do it if there is resistance to oral agents and gonadotropins are not easily available, and it also increases the risk of increases the chance of natural conception without increasing the risk of multiple pregnancy. So if the patient does not want the option of IVF, then maybe an ovarian drilling option should be okay, and you should know how to do it, how to do it, how to do it. I've seen a video of someone, this was very, very many years ago, who did an ovarian drilling, and this patient was 27 years old and came to me with amenorrhea, FSH of 120 and LH of 80, and she was menopausal at 27. And the reason was, when I asked the video, she had a video, I asked the video, there were exactly 100 holes in this ovary and 100 holes in this ovary. I mean, they basically cooked the ovary. So you can't do that. If you don't know how to do ovarian drilling, don't do it. Okay, but if you want to do it, know about it. Thank you very much.